Hello friends, this is a case of robotic fundoplication. Here left side we have a traumatic grasper and right side we have a needle holder, that is the mega needle holder with the seizures inbuilt. Now we are opening the peritoneum over the pars flaccida, that is the pars flaccida is just anterior to the caudate lobe of the liver, and we are starting it for the separation of the peritoneum and the mobilization of the esophagus. So we can see here the right crus is visible and the peritoneum over the right crus will be cut by the ligation. Here ligation assistant is holding. So once you will open the peritoneum, then lateral mobilization of the right side of the right crus from the esophagus can be mobilized. This is slowly opening the small thin peritoneum over the right crus, and that will make a good plane so that you can mobilize the esophagus from the right crus. So this is the blunt dissection. Most of the time in the fundoplication you should try to do as much as possible the blunt dissection, and at least 5 centimeter of the esophagus has to be mobilized so that you can get a floppy wrap and floppy fundus, so that you can have the floppy fundoplication. So this is the lateral mobilization on the right side, and slowly it will continue with the posterior mobilization of the esophagus. So this white color is the right color of the plane of dissection, and the left hand atraumatic grasper is just anteriorly pushing the esophagus, and slowly this with the small window of the pars flaccida you can mobilize the posterior mobilization of the esophagus. So this patient has no hiatus hernia, it is a pure Los Angeles classification grade 3 GERD, and we can see slowly the retroesophageal tunnel will be formed so that we can take a wrap. And posterior mobilization of the esophagus is the most important part of the fundoplication. And here we are using the telescope, that is the 30-degree telescope, that is a stereoscope of the Da Vinci, and slowly the posterior mobilization is continued. Now it is reached up to the left crus, and this part of the fundus is anteriorly pushed so that the retrogastric tunnel will be formed. This right hand instrument is the mega needle holder with the seizures. The base of these sutures has a seizures. So if you have a small flimsy tissue, you may cut it with the cold seizures, and it is also useful once you will tie the knot, then to trim the suture it will be used. So now this is the anterior mobilization. This vessel we will not injure, we will go in the peritoneum just and shaving this vessel and then continue the anterior mobilization. So, you may use the robotic harmonic or the vessel sealer, but here we have the ligature, which is the laparoscopic ligature, and our second assistant surgeon, he is dissecting the peritoneum anterior to the esophagus, so that we can minimize the minimum number of the instrument can be used. So, now it is the left lateral mobilization. We can see this is the left crus, which is just in front below the needle holder, and this is we are inside the posterior mediastinum, and anterior and left mobilization of the esophagus is carried out, and this is the anterior mobilization, and the left crus is also visible. So, now this is the peritoneum over the left crus, and here the again assistant is cutting the peritoneum over the left crus, so that you can do the left lateral mobilization. Now, little cordial traction is given over the gastroesophageal junction. So, further mobilization of the esophagus from the mediastinum will be carried out. During left lateral mobilization, you should be careful that you should remain as medial as possible. Going more laterally, you can open the left mediastinal pleura. Most of the time, if the assistant will hold the fundus and give the cordial traction, then this mobilization will be easy. But here we are using the left hand robotic grasper to give you the traction, and this anterior mobilization is complete. The posterior vagus you can see, which is attached with the esophagus. This is the right lateral mobilization, that is little more mobilization is required. And at this point you can see the posterior vagus, which is attached with the esophagus, little white color, that is also visible. So, here both the crus is visible, right and left both we can see easily, and esophagus is crossing in between. Again, we will ask our assistant to cut this part of the peritoneum so that we have a sufficient space to bring the fundus and to make the wrap. Now, this is the mobilization of the stomach. At least 10 centimeter of the fundal part of the stomach should be mobilized so that you can have a floppy fundus, and then that will give you the floppy nition. So, here also we are just supporting the short gastric and the fundus, and the main part of the dissection is carried out by the assistant surgeon by the ligation. He is separating the short gastric from the fundal part of the stomach. So, basically we cannot see it as a truly robotic fundoplication. It is a robotic assisted laparoscopic fundoplication. Here at this point you have to be little more careful, because you will get always the adhesion with the stomach, with the spleen, and we should be careful that the parenchyma of the spleen should not be teared off, and this is a very vulnerable area of the bleeding also. So, we should be careful. At this time, medial traction of the fundus is important, so that you can have a proper visualization for seeing those adhesions from the stomach to the spleen. So, now this is separated, and just some of the fat which is present at the just anterior to the left crust will be also separated. So, now we have enough floppy fundus. Now, again coming back to the right side, we will check that posterior window is enough. And from here, this posterior window, you can clearly see the fundus of the stomach is visible. So, now this is the taking the wrap from the posterior, and then we will check the shoe-shine effect, just to make it sure that you have the proper mobilized fundus. Now, the final part of the fundoplication will be carried out, and we are using ethibond suture to do the plication. So, here the assistant has dropped the suture, and one of the biggest advantage of the robotic is suturing skill. So, we can suture it very easily. So, again the fundus will be taken from behind the esophagus, and before the plication suturing we will do crural approximation. So, here assistant is retracting the esophagus, and these are the right and left crusts you can see, and that will be approximated by the ethibond suture. So, here 2 bite is taken, and the knot will be tightened. When you do the crural approximation, we should not be do very tight approximation, and we should take care that at least 5 millimeter gap should must be present in between the esophagus and your suture which you are using for crural approximation. So, this is simple surgeon's knot. And we can appreciate how much easy is to tie the knot in the robotic, and this mega needle holder with the scissors will cut the suture as well. So, now the fundus is taken again, and then the final part of the surgery will be done, that is stomach to stomach will be sutured. Little cordial traction always is supportive. Little bit muscle of the esophagus can be taken, and the first knot will be tightened. So, now all the knot is over, and we will remove the instrument, remove the Nathanson lever retractor, and the undocking of the robot is performed. So, thank you very much for watching this video. Have a nice day.